It is wonderful to see so many people joining us from the region from so many different countries. As many of you know, the International CML Foundation has a mission to improve outcomes for CML patients around the world. So it's fantastic that we can talk specifically to a group of you from Latin America today. People will continue to join, so I'm just saying a welcome as leader of the International CML Foundation. Hopefully many of you are familiar with our work, which spans through to providing best practice CML education in meetings like this, through to facilitating discussions and networking so that we can continue to improve treatment for CML, along right through to our programs which cover research in genomics and TFR, with obviously the hope to cure CML. So this discussion group program is a new one for us, and we're really delighted with the opportunity to spend time in Latin America and focusing on the challenges in CML treatment that are specifically relevant to you here. And it's our opportunity to also learn from you. So we would really appreciate your comments on the topics, your challenges to the experts that we have here. And we thank all of our speakers for their time this morning. We hope to see you on our future group discussions at the end of April and at the end of May. And please feel free to contact the International CML Foundation moving forward. So that's my welcome as the ICMLF Chief Executive. I'm going to hand over to my colleague, Arlene, who is going to take us through the programme for today.
So hi, everyone. Yes, I'm Arlene, and what a pleasure it is to greet you all. Okay, so our first topic for discussion today is the treatment of pediatric CML. And it's my great pleasure to introduce Dr. Norma López-Santiago from Mexico City. Norma is the head of the Department of Pediatric Hematology in the National Institute of Pediatrics in Mexico City. Norma, thank you so much for joining us today. Such a pleasure. And our other expert for this session is Professor Nobuko Hijiya from New York in the USA. Nobuko is a giant in the fields of pediatric hematology, oncology, and stem cell transplant. She is a Herbert and Florence Irving professor and head of pediatric oncology at Columbia University Irving Medical Center. Welcome to you both. Such a pleasure to have you here.
Thank you.
So, Dr. Norma, if you would like to share your slides with us, please. And as you're getting your slides up, I'll share with the audience how we will run the session. So Norma will spend a couple of minutes highlighting some of the key issues and problems that she faces in treating pediatric CML in Mexico. She will present a case, and then Nobuko will respond to the case, and then hopefully we can open up to you, the audience, for some comments or questions. Then Norma will present a second case, Nobuko will comment, and we'll open up to the audience for a longer period of time where you can ask any questions, raise issues, make comments about any area of pediatric CML that you like.
Thank you very much for the invitation. Now I will to speak in Spanish. Agradezco mucho la invitación para participar en esta reunión sobre el impacto de la leucemia mieloide crónica en pacientes pediátricos en América Latina y particularmente hablando de México. En México tenemos un problema muy importante que empieza por el sistema de salud que tenemos. El sistema de salud está dividido en seguridad social y a su vez la seguridad social está dividida en tres grandes grupos. Uno que es la seguridad social para los trabajadores que trabajan en industrias privadas. La segunda es la seguridad social para los pacientes, los individuos que trabajan para instituciones gubernamentales. Y el tercero son otra seguridad social, que cada uno tiene su propia seguridad social paraestatales. Entonces, esto hace que, aunque hay muchos pacientes que tienen seguridad social, estén muy divididos y cada uno de los sistemas de seguridad social tiene sus propias reglas y forma de funcionamiento. No todos tienen los mismos recursos. Para todos aquellos pacientes que no tienen seguridad social, se creó en 2005 un programa que se llama Seguro Popular y que en este sexenio, el presidente López Obrador decidió cambiarle nombre a Instituto de Seguridad para el Bienestar. Y es el grupo que cubre alrededor del 40% de la población en México, o sea, pacientes que tienen o individuos que tienen laboran en forma independiente y que no tienen ninguna forma de tener seguridad social. Entonces los 4 sistemas de salud actúan en forma independiente y eso hace que el registro de enfermedades y el seguimiento de enfermedades sea difícil y que no se puedan hacer propiamente programas nacionales, ya que cada una de las instituciones tiene diferentes recursos. Hablando del Seguro Popular que surgió en 2005 y que inicialmente cubría
Norma,
a niños
Norma, may I interrupt and just ask, please, if Carolina would quickly summarize in English what you've said so far? Maybe Carolina can't get on. Rafa or Lilian, would you like to quickly summarize?
Yeah, Dr. López-Santiago gives a brief summary of the kind of attention in Mexico City of different institutions in Mexico. So it makes the treatment and evaluation so quite different for patients. And not all institutions has the same resourcement for treatment and follow-up for pediatric patients. This is in summary what Dr. Norma López in the past slide said.
Thank you, Dr. Hurtado. La epidemiología de la leucemia mieloide crónica en México la tenemos a partir de 2007, que cuando surgió el Seguro Popular, pues la primera enfermedad que cubría era precisamente leucemia. Posteriormente empezó a cubrir todos los cánceres infantiles y actualmente tiene ya una cobertura prácticamente universal para todos los pacientes que no tienen seguridad social. Este es uno de los registros que se tiene más completos en este grupo específico, pero que como ustedes comprenderán no incluye a todos los pacientes que sí tienen seguridad social, sino solamente a los pacientes que se trataron bajo este esquema de Seguro Popular. En este periodo se diagnosticaron 14,178 pacientes pediátricos con cáncer y de ellos el 49,8%, la mitad prácticamente, tenían leucemia. De esos pacientes con leucemia se registró 198 pacientes con leucemia mieloide crónica que ocupan alrededor del 3% de las leucemias en la edad pediátrica, que es muy similar a lo que se reporta en otras poblaciones. Doctor Hurtado.
Yes, in the group of Seguro Popular in Mexico, we not take in count all the patients of security system, only the patients who are around 40% of our population in Mexico, in the whole country. It was a study from January 7 to 12. There was 1,478 pediatric patients registered with the cancer program in this kind of programs as Seguro Popular, Popular Security. The government covers this kind of patients. And as you said, there was the registry of acute lymphoblastic leukemia, myelogenous leukemia, and there was only 198 patients and represented 2.8% of all cases of leukemia in this whole group.
Los problemas para el diagnóstico, primero es la gran mayoría de nuestros pacientes consultan por dolor abdominal. La esplenomegalia, que al igual que en el adulto suele ser masiva, con mucha frecuencia es confundida con tumores sólidos. Y entonces esto retrasa el seguimiento de nuestros pacientes y el diagnóstico. Con mucha frecuencia, el médico de contacto primario, que no siempre es un hematólogo, confunde la leucocitosis con una leucemia aguda y empieza a tratarla como tal hasta que tiene los resultados de estudios genéticos o moleculares. Y por otra parte, la disponibilidad que tenemos en México para estudios genéticos y moleculares no es universal. muchas de las instituciones que tratan pacientes con leucemia y leucemia mieloide crónica no tienen la disponibilidad y entonces tardan entre 2 o 3 meses para tener un resultado genético y más aún tener un resultado molecular.
In Mexico, the main consultation that patient goes with the normally primary doctor is splenomegaly that sometimes is confused with abdominal tumor, and this confusion makes delay in the diagnosis. So in the other, leukocytosis is treated as acute leukemia in some of the patients due to they are not good morphology studies and researchment for define better what is going on in the blood of these patients. And the last, the poor availability of genetic and molecular studies in some centers in these pediatric facilities.
En cuanto al tratamiento, antes de 2004, la única posibilidad que teníamos de tratamiento era hidroxiurea y busulfán. A partir de 2004 empezamos a tener posibilidades de ofrecer trasplante de médula ósea a estos pacientes y en 2005 empezamos el tratamiento con inhibidor de tirosinquinasa, con imatinib, apoyados por the Max Foundation. En 2012 ya se autorizó como un tratamiento de primera línea para pacientes pediátricos el uso de imatinib y ese ha sido el tratamiento que hasta la fecha sigue siendo la primera línea de tratamiento. Apenas hace 2 años es que se autorizó el uso de dasatinib en pacientes pediátricos, tanto para leucemia mieloide crónica como para leucemia aguda linfoblástica Filadelfia positivo. Otros inhibidores de tirosinquinasa de segunda y tercera generación no están autorizados para su uso en pediatría.
Arlene, I can comment if you want. I think you can hear me now. Okay, sorry for that. So she commented about the difficulties in the diagnosis, in treatment, and that bone marrow transplantation was the first option in 2004. And they started with imatinib, thanks to Max Foundation in 2005. Then imatinib have been authorized for pediatrics patients in 2012. And unfortunately, they have access to second generation TKI since 2021, but dasatinib is the only one who has been authorized. So they have just dasatinib and not the other ones.
Y bueno, una vez hecha esta introducción, pasaré al primer caso, que es un masculino de 2 años de edad, que inició con síntomas respiratorios y pobre respuesta a los tratamientos usuales. Por esa pobre respuesta se tomó una biometría hemática en la que se reportó leucocitosis y entonces fue enviado al Instituto Nacional de Pediatría. A la exploración física no había ninguna alteración, no había visceromegalias y prácticamente la única alteración era un cuadro leucoeritroblástico en sangre periférica. Se hizo, y ese cuadro leucoeritroblástico morfológicamente era compatible con una leucemia mieloide crónica. Se hizo el estudio citogenético y se documentó aquí está equivocado, es una translocación, un cariotipo 46XY con una translocación 922. Y se estableció diagnóstico de leucemia mieloide crónica en fase crónica. Por la edad, iniciamos tratamiento con imatinib a 350 miligramos por metro cuadrado cada 24 horas en noviembre de 2007. 3 meses después, en el estudio de control, teníamos una PCR para translocación 922 negativa.
May I ask you a question, or should I do that when she's done with the presentation?
Ask now, why not?
Oh, okay. So what is the sensitivity of the PCR when you say negative?
Era solo en esa época solo teníamos PCR cualitativa. Hicimos también estudio de FISH en ese momento y también fue negativo.
She said that they have qualitative PCR in that time. So it wasn't, they weren't able to answer your question because of the method of that time. Dr. Mauro, I think you have your hand raised.
I did. I was just wanted to clarify the dosing. You have the abbreviation SC, meaning like subcutaneous. Oral imatinib?
Body surface. Body surface.
No, that's meter square. But then SC,
Right.
I think you meant orally. Yeah.
I had the same question, Mike. Yes.
Dr. López-Santiago, the medication is oral, yes?
La medicación es oral, el doctor, sí.
Sí,
Doctora.
sí, es oral.
Just wanted to clarify.
Yeah, imatinib by injection would be fabulous, really. There are many patients who do not want to take imatinib by mouth. I'm struggling with one patient currently. He has Philadelphia positive ALL. He doesn't want to take imatinib. That's a challenge, but unfortunately, oral imatinib is the only form currently, I think. Okay, thank you for clarification.
Sorry, it was a translation problem. It's body surface. You say superficie corporal. So
I see.
that's
I understand now. Right. Yeah. And in terms of the dosing, the dose of imatinib in pediatrics, that actually varies depending on the study. In the United States, in Children's Oncology group, the standard dose is 340 milligram per meter square. Dr. Storp of Germany has published a German study. They used 300 milligram per meter square. Another study, another large study was published by Dr. Millot from France. That was a post-marketing study. They used 260 milligram per meter square. So that varies, but 340 is the dose we are using in North America.
Tú ya 2 años después, y por la edad del diagnóstico de este niño, habíamos estado haciendo RT-PCRs y ocasionalmente FISH. Todos fueron negativos para translocación 922 y propusimos al paciente un trasplante de médula ósea haploidéntico que los padres rechazaron. Este niño no tiene hermanos. Los padres lo rechazaron y continuamos tratamiento con imatinib. 10 años después de darle imatinib, no seguíamos teniendo PCRs ya ahí semicuantitativos y FISH negativos para translocación 922 y decidimos suspender en forma electiva el tratamiento en mayo de 2018 en base a lo que se había propuesto en el adulto de suspender después de 7 años de tener una PCR negativa. Y seguíamos cada 2 meses con determinación o búsqueda de translocación 922 ya con un estudio cuantitativo. Y entonces, 6 meses después, tuvimos una biometría normal, médula ósea normal, pero ya una determinación positiva y decidimos reiniciar imatinib. Aquí ya este niño ya tenía 13 años y pesaba más de 40 kilos. Entonces, iniciamos este tratamiento con imatinib a 400 miligramos por día y las PCR fueron disminuyendo. La última, previo a su egreso a un hospital de adultos, fue con 0.27%.
The comment perhaps, sorry, just comment for the audience when she asked, when she explained the positive PCR in 2018 when the patient discontinued and you said that the patient had RT-PCR, this was real-time quantitative PCR standardized, for example, this is one question. And the other one, if you can perhaps explain the monitoring you made with the patient, it was once per month, and why he's on 0.27% now, and in previous, this is a descending curve, or just an explanation of this, a comment, sorry. Doctora, no sé si se entendió. Yo le preguntaba si la RT-PCR estaba estandarizada en escala internacional y si lo hicieron cuantitativamente mensual al seguimiento de este paciente pequeño.
Una vez que estaba en vigilancia, la hacíamos cada 2 meses. Y cuando salió positiva, 6 meses después, era todavía semicuantitativa.
Semi-quantitative.
Ya la tenemos estandarizada en cuantitativa.
They said that they have a semi-quantitative PCR for the patient when he discontinued. And the number is clarified 0.27% when they have the PCR quantitative now. But the patient, when the patient discontinued, it was negative, she says, but not in the standardized lab.
Right, and so I guess I don't know what semi-quantitative means, but it's not. I mean the sensitivity of the PCR is not really clear, I guess.
Claro, le pregunta qué significa semi-cuantitativa la doctora.
No las reportaban en base a transcritos de ABL.
Okay. She didn't, the PCR was not reported in base of the ABL transcript, but I think it's like a qualitative, she means it's not a standardized one. And perhaps in that occasion, it was not the best option, but perhaps now she would do it in a standardized way.
Maybe Mike has a comment or question.
Oh, just a quick comment. I was going to say it. I think we might all be thinking if the patient might have met the criteria we look at it in both pediatric and adult patients to successfully stop treatment. Nobuko, maybe you can comment on the state of TFR in children. And then as an adult doctor, I'd love to see the patient and help him with his PCR to get that 0.27% into better territory, because that's just a little bit above a major molecular remission, which is probably a reasonable remission. His blood counts look excellent, but I think there might be opportunities to improve on that.
Well, in pediatrics, TFR, treatment-free remission after stopping TKI, the data is very limited. There is only one study that was published by a Japanese group. So far, that's a very small study, including like 20 patients. In the children's oncology group, there is an ongoing prospective study for TFR, and we do not have the results yet. But taking this Japanese group's data, it seems that the TFR rate is probably about the same as adults in the pediatric patients. That means like about 50%, 40 to 60 maybe. And in this patient's case, it's not totally clear to me how long he was in this level of negative PCR, but by taking the NCCN criteria, the patient should have been on the TKI at least for 3 years, which is definitely more than 3 years, and less than 0.01% by international scale for greater than 2 years. So maybe he was in that range. But regardless, so the molecular level came back positive, correct? How long after did that come back?
How long after what? Sorry.
The molecular, I mean, the PCR was negative when he stopped TKI, I mean, imatinib, but that became positive again, correct?
¿Cuánto tiempo estuvo con PCR negativa?
So that was after 6 months, is that right? After 6 months, he had molecular relapse, maybe.
Luego de los 6 meses tuvo la recaída molecular.
Y antes de esos 6 meses, él tenía 10 años con PCRs y FISH negativos.
10 years, yes, okay, negative. Y cuando recae, ¿cuánto tiempo pasó hasta la recaída que usted pone positiva? ¿O 0.27?
6 meses. 6 meses después de que suspendimos el tratamiento.
6 months, yes, after discontinuation.
Okay, and since he started this dose of imatinib, which is a standard dose in adults, how long has he been on imatinib again? he still has 0.27% as of now, correct?
Sí, ¿cuánto tiempo estuvo con imatinib desde que empezó? Y ahora tiene 0.27%. ¿Estuvo cuánto tiempo?
Tiene 4 años.
4 años desde que reinicia el
Desde que
tratamiento.
recayó molecular y
Yeah,
reinició
sí.
tratamiento hasta este momento que ya es adulto y lo enviamos a hospital de adultos.
Okay, 4 years. 4 years since he reinitiated imatinib. He's not achieving MMR, o sea, está aún sin alcanzar una respuesta molecular mayor, digamos.
Así es.
Soledad Undarago has her virtual hand up for a question.
I wanted to ask if this PCR 0.27% is the best he has achieved, or he had better response and now he is losing. Doctora López, le
¿Una mejor
pregunto
respuesta? Sí, en castellano.
¿hubo alguna vez mejor respuesta que el 0.27%?
A partir de la reactivación, de la recaída molecular, tuvimos sí 2 reportes de PCR negativo, pero era este reporte en el que teníamos en base a transcritos de ABL. Este último, que no son comparables con este estudio, que ya es un estudio cualitativo. O sea, sí tuvimos aparentemente una mejor respuesta, pero no es la misma metodología que utilizamos para el estudio.
Claro, no son comparables con
Claro.
lo anterior. ¿Y cuánto tiempo lleva? ¿Cuándo se trasladó? ¿Hace cuánto tiempo que se trasladó al hospital de adultos?
Lo acabamos de trasladar este mes.
Ah, bien. Bien, gracias.
I might take the opportunity to say we've spent quite a bit of time on this case. We're now into time where we were to open up to the whole audience for a broader conversation and Q&A. I wonder if we'll just move to that. Norma, would you like to just finish your presentation on this case, and then we'll just open up to a general conversation? How would that be?
This case is done. Este caso es lo que completo.
Okay, there's one question here from Alejandro Lacanzo, who wanted to ask you if, do you think the end of treatment would have been different if the technique used would have been more sensitive? For example, a digital droplet PCR.
Yeah, no. Probably Mike would have a better answer, but having the unclear sensitivity of the qualitative PCR that they used, certainly droplet PCR would be digital PCR might be even better, but just usual quantitative PCR might have changed the outcome. Mike, any comments?
Sure. I think I'm not sure we know how to use digital PCR just yet. I think there's some data that tells us it's probably helping us predict patients who may not be successful coming off treatment. I think we can start with the basics, though. I think good input, better study of pediatric cases and the variables that might be specific to pediatrics. Good data going in, careful monitoring and management of relapse. In this case, maybe managing what could be suboptimal response after retreatment, which isn't something we generally see in adults. We're lucky. I was very skeptical. TFR in adults, retreatment, same dose, same drug is fairly successful. So those are just some comments. Sure, always room for better PCR, but also just start with the basics.
Agree. And in terms of TFR, stopping TKI, in the adult oncology world, that has become a standard practice, like, NCCN guidelines and the European Leukemia Net guidelines are there. In pediatrics, we don't really know how children do. We have only a very small amount of data. So when clinicians come to me and ask me about the stopping TKI, I ask them not to again, until we have a better data, I don't think that should be done as a standard of practice. Although it's so easy to just stop TKI, and that's so, that may attract the patients for the idea, but I think we have to be very careful. Even in adult oncology world, again, Mike knows a lot more, but careful monitoring and good, teaching for the patients, they are really critical. So it's not as easy as we think.
Rafa, you have your virtual hand up.
Yes. My question is if you, to Norma, did you practice or send mutation studies in this patient?
Mutaciones.
Oh, sorry, go ahead.
No tenemos forma de estudiar mutaciones.
They have no possibility of studying mutations. This is the response of Norma.
And clearly that's a major challenge and issue too. So many people
Yes.
in Latin America. Norma, I think you had some specific questions. Actually, there's Lillian. Lillian?
I would like to ask, why didn't you change it to dasatinib? Or do you have problems to access the therapy? Si tienes problemas para acceder al dasatinib, ¿por qué no se cambió de inhibidor de segunda generación?
Cuando este niño tuvo la recaída molecular, no teníamos acceso a dasatinib. Hoy ya lo tenemos, pero en ese momento no lo teníamos. No consideramos en este paciente en particular cambiarlo a dasatinib.
Pero entendí que llevaba 4 años sin recuperar la respuesta molecular mayor.
Cuando teníamos estas respuestas en donde no, esta es nuestra primer determinación molecular, cuantitativa. Exacto. Y las anteriores que habían estado negativas, pues no eran un indicador para cambiar de inhibidor.
I asked her if why she didn't change it to a dasatinib, and she says that before she didn't have quantitative PCR, so they were negative.
Sorry, one comment that is very... perdón, Lilian. ¿Seguías? No, perdona.
No, era eso para... No sé si entendieron.
Sí, yo creo que sí. I think that for Michael and for Professor Nobuko also, it's very important to clarify perhaps that in Latin America, on our countries, perhaps there are some countries that they have difficulties in access to quantitative PCR or mutation. But this is such an important topic that I think that perhaps I hear this case, and in Argentina we have some projects that we make the mutations free under research projects, that we must apply this in other countries. So I think this is very important for them to have access to these important tests.
And that will be a significant issue for discussion in our second Latin American discussion, which is scheduled for the 27th of April. So I'll get a little push in for that there. So as I say, we have Dr. Norma and Dr. Nobuko and a number of pediatric hemato-oncologists out there who must have lots of questions. Please put your hands up or use the chat. Soledad Undaraga, you can have your hand up again.
No, I only wanted to comment that at least in Chile, in our country, we have access to the the QR, the quantitative tests, and to of course to the qualitative and cytogenetics, and also mutations for at least most of the for all of the children, and in the public system. In the private, I think they also have them because there's a plan, a program that it's called HES, that it means that their treatment is guaranteed. So they have access to all these tests And we also have, I don't know in children, but at least in adults, we have all the inhibitors. And that is, I think, a very good goal that we have achieved. And we hope to keep it on and don't lose that.
Anyone care to comment on that? If not, we'll move on to Paulina Diaz.
Yes, hi to everyone. I work in Chile, so the information of Dr. Undurraga is the real of our children. We treat the 80% of the children people in the public system, and we have imagining and all the studies for our patients. It's a very important information. I was thinking about another patients who present bone pain in important time with TKI inhibitors. So I would like to ask to Dr. Nobuko your experience. We have children with imatinib with very bone pain. So we have changed to dasatinib with a very good response, but another months with imatinib and no very good response. It's a real no frequent adverse event, but it's very important to the patient what it presents.
Like bone pain, muscle pain, I think they are very common side effect with the TKIs, especially imatinib. In some data, it has been said that it's up to like, it can happen up to 20-30% of the patients in adults, I believe. Mike, please correct me if I'm wrong. And in children, I think the instance is pretty similar. In those cases, we normally try to alleviate that by using like acetaminophen or like what's the Motrin's generic name? I'm blanking out.
Ibuprofen.
Thank you, ibuprofen, thank you. So we use all those non-steroidal drugs. And then if the patients really cannot tolerate, then it sounds like now there is a option of dasatinib in South America. So that might be a consideration. But Mike, I don't know what your experience is, but from my limited experience, it sounds like initially patients have those pains, but then as they continue, some patients do have improved pain. What is the experience in the adult oncology world?
I think you're hitting the points. I think most AEs generally aren't worsening or intensifying past 12 to 18 months, but that's a long time, especially for a young person to withstand.
Right.
I treat the same. I think it can be an intolerance. I think intolerance is a challenge for a younger patient, just like it is for an adult. Even more so understanding what's, why the medicine makes me hurt, basically. And I have a cheap and easy solution that, with withdrawal from TKIs, we sometimes see bone pain and musculoskeletal symptoms too, which may be linked to some of the AEs we see on the drug. And sometimes antihistamines help, which I don't really have a clear answer for that. It may be due to KIT modulation, but it may be a low toxicity, potentially efficacious idea to consider, again, cautiously and dose properly in the pediatric population that, because some of them are sedating, especially the low cost options. That's not a good thing. So non-sedating antihistamines could be an option too, besides anti-inflammatories. While I have everyone's ear, I thought, we talked a lot about mutations, and I think that is a very important topic. Not having access to mutation testing, I imagine is a huge challenge, and I really commend my colleagues around the world who manage CML, with limited access or sometimes not even clear access to mutation testing. I just took a quick look just to remind myself, but this case is this young gentleman who was lacking MMR after restarting imatinib. I think it's sort of a new era of where we don't understand the biology of disease after treatment stop and restart. But ironically, I don't know if mutation testing would have been so helpful here. Simona Severini published on, the yield of mutation testing when someone has missed a milestone or has lost a milestone. And suboptimal response, failure, lack of MMR is a pretty low yield. In fact, it was 0 in one of her presentations for mutations. Lack of a cytogenetic response, loss of a cytogenetic response, of course, loss of a hematologic response. Those are definite. So if we're thinking about limited opportunities for mutation testing, I might have saved my assay for a different patient rather than this, and maybe empirically switched. Although, of course, you know, just this morning in the ICMLF, we saw Sue Branford talk to us about molecular testing, and you present some eloquent work on next generation sequencing and understanding the clonal hierarchy at CML. And we'd love to understand exactly how mutations develop and non-BCR-ABL mutations and how they interplay. But just practically speaking, I just wanted to make that point that I think we'd love to have the ability to be complete, but if we have limited resources, sometimes we have to just be focused on what the pretest probability is even.
I totally agree with Mike about the yield of mutation testing. You know, Mike, maybe you can make a comment. I do get lots of questions from many clinicians. Maybe this case is a little bit different situation because he stopped TKI and then BCR-ABL came back, but many patients still do not achieve MMR even after a couple of years. And then as long as the level is like close to MMR, like 0.2%, 0.25%, I kind of recommend them to continue, because even after 2 years, you know, over time, some patients do go to MMR. I don't know what your approach is in this kind of case.
When I can, I think I try to be always aiming for deepest remission, and even a remission from which a treatment cessation is possible. But your point is very well taken, that failure to achieve a cytogenetic remission is much more ominous than failure to achieve a molecular response. The time it takes to achieve a molecular response is probably, we need to be more patient. Even our American NCCN guidelines only have, you know, softer language regarding failure of achieving MMR. I generally look, I'm hoping it's at an adult patient, I'm hoping it's at 12 months. I'm really hoping it's by 18 months. I'm willing to wait to 24 months or sometimes even beyond, especially if transcripts are stable and maybe falling slowly. So we have to not be too reactive or overreactive. But
I think we have time for one more issue to be discussed. Adherence in children and adolescents. Would you care to chat a little bit about that? And then I think we'll have to close off the discussion, but please.
Looks like Dr. Rafa has a comment or a question.
Sorry, Rafa.
Yes, my question is that in the pediatric population, the criteria for stop therapy, it will be the same that in adults. I mean, will be the LTN or the NCCN criteria for stop therapy will be for pediatric population the same for adults?
So in the current children's oncology group study that is ongoing, we are indeed using the same criteria. That means TKI more than 3 years and MR4 more than 2 years. And if this study proves that the TFR rate is reasonable, as good as adults, then that may become standard in pediatrics. And
thank you.
You're welcome. In terms of the compliance issue, well, not only in pediatrics, I'm sure Dr. Mauro has similar challenges in adult patients. Of course, compliance is the most important factor. And you know, there are many things that we could do. We could try, like education of the patients, and we have had there some ideas of research studies to use like electronic cap to see if the patient really opened the pill bottle. There are some similar studies out there for patients who are taking 6-MP for ALL and patients with sickle cell anemia who are taking hydroxyurea and so forth. So we have kind of entertained this idea in children's oncology group, but we have not got there yet. Many years ago, my colleague had a teenage boy who had the most horrible compliance. And then, of course, he never even went to a hematological remission. So we had to confine him in the hospital, and we had to give him omacetaxin, which is given by subcutaneous injection. Then he did go to hematological remission, at least complete hematological remission, but then he was lost follow-up. We don't know what happened to him. So again, compliance is a really huge challenge. I don't have a great answer for that question.
Thank you. Thank you very much for that. Thank you, all of you. Thank you to Dr. Norma. Thank you to Nobuko. Thanks to the audience for some raising good issues and questions there. We didn't get to Norma's second case. And I think it's been a worthwhile discussion just to involve everyone. I will follow up and I'll provide you with Norma's case, with Nobuko's response. There are also some questions coming up in the chat that we haven't got to. I will get a response for you and get back to you as soon as we can.